Okay, well, I think we'll get started now. So thank you to everybody who has attended today. My name is Jennifer Boyko, and I'm the Senior Manager of Scientific Operations with the Canadian Longitudinal Study on Aging, or CLSA for short. Thank you for joining the webinar today, which is entitled Associations Between Body Mass Index and Cognitive Performance Among Older Adults and Analysis of the CLSA Database. Before we begin, I'd like to acknowledge that the CLSA's National Coordinating Center at McMaster University are both located on the traditional territories of the Mississauga and Haudenosaunee Nations and within the lands protected by the Dish with One Spoon Wampum Agreement. We also wish to acknowledge the land on which the University of Toronto operates, where our presenter is today. For thousands of years, U of T has been on the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, the meeting place is still the home to many Indigenous people from across Turtle Island. And as attendees of this webinar today, we encourage you to continue your learning following the webinar and to acknowledge the original inhabitants of the lands where we currently have the privilege to do our research, live and work, wherever that may be for you. Now let's review a couple housekeeping points and reminders. Everyone but the presenters will be muted throughout the webinar. If you need to change or test your audio during the webinar, you can click on Audio Settings, which is on the bottom of the Zoom window. At the end of today's session, there will be a question and answer session. If you have a question for the presenter during the webinar, you can post it into the Q&A box, which is located in the bottom of the toolbar. The questions will be addressed at the very end of the webinar, and please note that questions will be visible to all attendees. If you have any technical trouble during the webinar, we ask that you use the chat box, which is a way to communicate with our webinar team. The chat box is usually on the side of your screen. And finally, a feedback survey will be launched at the end of the webinar, and we invite you to complete it after exiting the Zoom session today. This brief survey will provide us with important feedback that we can use to plan future webinars. Okay, now moving on to the important part of today, the webinar, again entitled Associations Between Body Mass Index and Cognitive Performance Among Older Adults and Analysis of the CLSA. The webinar will be presented by Dr. Nadine Akbar at the University of Toronto and Humber River Health. Dr. Akbar is currently a research chair in community connection at Humber River Health and an assistant professor in health services research through the Institute of Health Policy Management and Evaluation at the University of Toronto. She is currently leading a research program at Humber River Health focused on addressing the needs of marginalized communities, including older adults experiencing barriers to social determinants of health, predominantly from the northwestern Toronto region. So I now turn it over to Dr. Akbar.
Okay, can you see and hear me okay?
Yep, we're good.
Okay, perfect. Okay, so thank you so much for the introduction and the invitation to present today. So good afternoon, everyone, or good morning, depending what time zone you're in. So I'm delighted today to present some work that we've been doing looking at the association between body mass index, particularly obesity and cognitive function, using data from the CLSA. And so we know that rates of obesity are rising. So obesity is considered a global epidemic affecting approximately 1 in 3 Canadian adults. And obesity is associated with a number of negative health outcomes and is associated with greater risk of a number of chronic conditions, including Alzheimer's disease and dementia. And this relationship still holds true even when we control for vascular risk factors and independent of vascular and diabetes comorbidities. And depression could potentially explain this link. So depression is associated with higher body mass index, and we know that depression is associated with faster cognitive decline. So obesity is associated with a number of health conditions that could potentially be moderating this relationship between obesity and cognitive function. But also mild cognitive impairment, which is a risk factor for Alzheimer's disease and dementia, has also been reported in up to 50% of older adults with moderate to severe obesity. So in contrast to high BMI, low BMI has also been shown to be a risk factor for dementia as well. And we know that the levels of food insecurity are rising across Canada. And so there is concern that our population is not getting adequate nutrition. And so the levels of food insecurity are also higher among older adults living alone compared to older adults in other living arrangements. So low BMI is also a concern when it comes to cognitive performance in older adults. But I'm sure a lot of you have also heard about the obesity paradox, where obesity might be protective in some respects when it comes to cognitive function. So there are some studies showing that greater adiposity, so excessive body fat tissue, has a protective role, particularly when it comes to executive functioning. So it could be that greater fat tissue sort of prevents neurodegeneration or is protective, especially when it comes to adults over the age of 65 or 75, so in sort of the old category. And the association between obesity or BMI and cognitive function has been shown to vary according to various demographic factors. So for example, sex, based on sex, age, and race. So obesity has been shown to be more negatively associated with cognition in women, and this could be related to postmenopausal drops in estrogen level, which would affect sort of fat distribution and greater visceral adiposity. And this change in fat or deposition could lead to more detrimental effects when it comes to cognitive function. And also beyond age 65, and like I mentioned, in sort of the old category, higher BMI or obesity is suggested to be more protective. And increased BMI is also associated with faster decline, particularly in processing speed among African Americans compared to white Americans. So there are differences also demonstrated with regards to race. And this association between body mass index and cognitive function. And also among Asian older adults, it appears as though being underweight may be a significantly greater risk factor for cognitive impairment. So there are some studies showing that perhaps in Asian older adults that the effects of low BMI are more detrimental. So the association between BMI, particularly different classes of obesity, and cognitive performance, including the indication of mild cognitive impairment, has yet to be determined using a large Canadian sample, large Canadian database such as the CLSA. So we sought out to accomplish two main objectives. So first, to determine the cross-sectional association between body mass index / obesity classification and memory performance. Also, indication of mild cognitive impairment among Canadian adults aged 45 and over. And we also aim to look at whether changes in BMI between baseline and follow-up 1, so over approximately 3 years, whether changes in BMI were associated with changes in memory performance in particular. So we did hypothesize that there would be a presence of sort of this inverted U relationship that's been shown in the literature, where low BMI and higher levels of obesity were associated with worse cognitive performance, whereas individuals with normal BMI have the best cognitive performance. So we hypothesized an inverted relationship, but we did hypothesize that this relationship would differ according to demographic factors such as age, sex, and race in accordance to sort of relationships that I described earlier. And so with regards to objective 2, we also hypothesized that 3-year decreases in BMI would be associated with improvements in cognitive function, particularly for those who came from sort of from the obese range to going to the normal range, that those individuals in particular would show improvements in cognitive function. So just to sort of provide a recap of how body mass index is calculated. So the formula is weight divided by height. So BMI is generally used to estimate the amount of body fat, but it doesn't take into account the differences in weight between muscle mass and fat. So that is something that that is sort of a limitation that I'll talk about later. Body mass was measured within the CLSA, depending on whether the individual was in the tracking cohort or comprehensive cohort. In the tracking cohort, it was basically self-reported, whereas in the comprehensive cohort, my understanding is that it was measured directly. And these are the BMI categories that were used. And so the ranges are shown here as well. So underweight is on the BMI under 18.5, and you can see all of the different BMI ranges for the different BMI categories. So one thing I just wanted to mention is that, you know, BMI category in combination with the presence of different obesity related health conditions may determine, you know, what treatment approaches might be management approaches might be most appropriate. So for example, BMI of 27 and over, but in addition to having other obesity health related conditions may, you know, determine or may make a person eligible for, you know, medications to control obesity, whereas, you know, obesity class 2 and 3 falling into those categories generally would make you eligible for bariatric surgery, particularly obesity class 3, but obesity class 2, in addition to having other comorbidities, may also make an individual eligible for bariatric surgery. So different management approaches are appropriate for different classes of obesity in conjunction with the presence of other comorbid conditions. And so for objective 1, where we were looking at the link between classes of obesity and cognitive function, we just used the baseline data from the CLSA. So and data collection started in 2011, as you would know, and then for objective 2, where we were looking at the changes in BMI and associations with changes in cognitive performance, we used the baseline and follow-up 1 data, in which for follow-up 1 data, as you know, was collected between 2015 to approximately 2018. And in terms of the analysis, so we used ANOVA to determine the relationship between BMI classification and memory performance. So we used as our indicator or marker of cognitive performance, performance on the Ray auditory verbal learning test, delayed recall. And I'll talk a little bit about that later. And then for the looking at the association between BMI classification and indication of mild cognitive impairment, we use the logistic regression analysis, and we applied analytic weights to the models. And for the second objective, where we were looking for the association between changes in BMI and changes in cognitive function between baseline and follow-up, we used chi-square tests. So we categorized everyone according to the extent of their changes in BMI, and then also changes in memory performance. So as I mentioned, so we use the Ray performance on the Ray auditory verbal learning test as our indicator of memory performance. And we chose this because it's sensitive for detecting early cognitive decline and sensitive for distinguishing between persons with MCI and normal controls. So for this particular test, participants are asked to listen to an audio recording of a list of 15 words and then asked to recall the list immediately, and then again 5 minutes later. So for this, we actually we used the performance on the delayed recall, I guess, subtest. And each remembered correct word is awarded 1 point. So we entered raw scores into the ANOVA analysis because we did control for other demographic factors in the ANOVA. So age, sex, education, etc. were entered into the model, but we use the raw scores as our outcome measure in the ANOVA as well. And then mild cognitive impairment. So we define this as, so our first criteria was overall cognitive impairment on the battery of 4 tests of the CLSA. So performance in the lowest 5% on 2 or more of the 4 measures. So there had to be evidence of cognitive impairment, but preserved activities of daily living. So no functional impairment or mild impairment based on the ORS scale. So they're based on your score on the different items. You're given a classification. So individuals who were classified as having no functional impairment or mild impairment were, deemed to have, preserved activities of daily living. But this, in addition to the indication of overall cognitive impairment, we use as our criteria for mild cognitive impairment. And in terms of our second objective, so looking at changes in BMI and associations with changes in memory performance, there were 5 categories we use for determining the change in BMI. So individuals either had no change or they had an increase of 5 to 10% of baseline BMI, a decrease of 5 to 10% of baseline BMI, and then an increase and decrease of over 10% of baseline BMI. So there are basically 5 categories here. And then in terms of change in cognitive performance, so we use the reliable change indicator, which is one of the cognitive measures on that are part of the CLSA that are already computed. So there are 3 categories here. So either decline, so Z-score change of less than negative 1.65, having a stable performance, comparing baseline to, as I mentioned, we were comparing baseline to follow-up 1, so stable performance, and then improved performance was based on a Z-score change of more than 1.65. So this table just shows who we excluded from the analysis. So we had a total number of participants, and this is for objective 1 in particular. So total number of participants was 40,232. And so we excluded individuals with missing data, so no BMI data reported or no cognitive data, women who were pregnant, and this was based on self-reported, has a doctor ever told you had a stroke, mini stroke, Parkinson's, multiple sclerosis, epilepsy, dementia, or Alzheimer's. So anyone who indicated yes to those questions, we also excluded. So we did exclude individuals who reported having, or a doctor previously telling them they have dementia or Alzheimer's. And in terms of our sample demographics, so there was 51% females, 49% male. The age distribution you can see here. The most common age category was between 55 to 65. In terms of race, we sort of divided the sample into white and non-white, just based on the number of, the low number of participants that were in the non-white categories or our cultural groups. And so 96% of the sample was white, 4% was non-white, and the vast majority were sort of higher in terms of education level, so had a post-secondary degree / diploma. And then you can also see here the distribution in terms of province. And so most came from Ontario, but there was quite an even sort of distribution. And so in terms of our results, so this first graph is just showing the raw scores. So here you could see that the mean RAID 2, so delayed recall, as I mentioned, the mean raw score was 4.32. So this is the number of words correctly recalled after approximately 5-minute delay. But you see that there was sort of evidence for this kind of inverted U relationship. So you could see here that individuals within sort of the normal BMI range had the highest raw score on the Ray delayed recall, and the lowest score was found in the overweight group. However, I do want to mention that, and you could see here in the bottom, these are the percentages or the number of, the percentage of participants that fell into the different BMI categories. So the number of individuals who fell in the underweight range was quite small, so 291 participants, so 0.7% were in the underweight range, whereas the majority were in the normal or overweight range. So overweight actually had the highest percentage, so 40.6% of participants fell into this category, and then 30.9% were in the normal range. But you can see here there was this indication of an inverted U relationship. And then when we control for, all the other demographic factors, so in the ANOVA model, in the final ANOVA model, where we actually were testing for significance, there was still evidence for this inverted U relationship. So participants with normal BMI had the best performance, and then if we actually look at statistical significance, performance was significantly better in the normal, in participants with normal BMI compared to all other BMI classes.
Go to level 1, emergency department, acute room 3. Go to level 1, emergency department, acute room 3.
Okay, sorry about that. And then as I mentioned, we entered, different demographic variables into the model. So within the final ANOVA model, the following variables were also significant. So age was significant. So as expected, older age was associated with worse performance or lower scores on the RAID 2. Sex, males had lower performance. In terms of race, when we compared white to non-white also had lower performance. In terms of education, individuals with higher education level had better performance. Province, so there was differences across province as well. And then there was also a significant age times sex interaction where the slope was a little bit steeper. So I believe males had a sort of steeper decline in cognitive performance with age and sort of the older age categories. But even when after controlling for these different demographic variables, BMI did remain significant in the final model. So there was still evidence for this inverted U relationship and differences across obesity or BMI classifications and cognitive performance. And we didn't see, however, interactions between BMI and demographic variables. So as I mentioned in our hypotheses, we thought that this association between BMI class and memory performance may differ according to sex, age, race, etc., but we didn't see any significant interactions to suggest that. And then if we look at the results when it comes to indication of mild cognitive impairment, so if we look at rate of MCI, so the percentage of participants within each of the BMI categories, showing evidence of MCI based on the criteria that I described earlier. So the rate of MCI was 5 times higher in the underweight group compared to individuals with normal BMI. So across the entire sample, the rate was about 4.21, but as you can see, it was quite a bit higher in the underweight group. So this is just sort of the raw or just the overall rates. But then when we enter the data into the final logistic regression model, we see that underweight in particular was associated with higher odds of MCI compared to normal. So overall, though, looking at all the BMI categories, normal BMI was associated with significantly lower odds of MCI compared to being underweight, but also compared to obesity 1 and the obesity 3 categories. And so entering all of this data into our logistic regression model. So I'll sort of go through this piece by piece. So in the final model, the variables that I've indicated here were significant. So race. So non-white individuals had a higher rate of, higher odds of meeting criteria for MCI compared to non-white. With regards to age, there was a significant age times sex interaction. So what we actually found was that the odds of MCI went down, but then went up a little bit in women, but then so this was past 55. And then in men, the odds of MCI actually went down with age. So there was an interaction. There was sort of a differential pattern between men and women in terms of odds of MCI. And then across province as well, there were differences. So so as you can see here, Alberta, BC had slightly, or had, I guess, a lower odds of MCI, and then it actually was higher in the Nova Scotia group. So there were there was a bit of variability across provinces as well. But even after controlling for these different demographic variables, BMI was still significant in the final model. So individuals who are underweight had higher odds of meeting criteria for MCI, and the same was true for obesity 1 and obesity 3. And here again, we also didn't see a significant interaction between BMI and demographic variables. So these associations between BMI and odds of MCI, it didn't differ according to race, age, sex, etc., which is kind of contrary to what we had hypothesized. But this association, though, between BMI classification and odds of MCI, though, was significant even after controlling for these various demographic variables. And then with regards to objective 2, so looking at the change associations between change in BMI and change in memory performance. So we didn't see a statistically significant association here. So change in BMI over 3 years was not significantly associated with change in memory performance. And so as you can see here, the vast majority, so 90% had stable memory performance, so around 90%. Remained sort of, or there was no significant decline or improvement in memory performance after 3 years. And then as well, most people sort of stayed in the same BMI category as well. So 90% were sort of over 90% were kind of in the, didn't really change when it came to BMI or memory performance. Okay, so just to sort of to summarize, so overall, having a normal BMI was associated with the best cognitive performance, and as well as lower rates of MCI compared to being underweight and being obese. And so, this suggests the importance of sort of maintaining a normal BMI, and also provided further evidence for sort of this inverted U relationship that we've seen in other samples internationally, but haven't really looked at specifically in Canada. But there was, evidence for this inverted U relationship. And so I'm going to present some hypotheses as to, and some potential reasons why this pattern was observed and has been previously observed. So So why is normal BMI associated with better cognition? So one hypothesis stems around leptin. So leptin is a hormone secreted by adipose tissue that aids regulation of appetite. And in animal models, leptin has been shown to slow neurodegeneration, increase beta amyloid clearance, and improve hippocampal neuron survival and promote synaptic plasticity. So it seems to have, neuroprotective effects. And there is a study showing that among those with normal BMI, higher levels of leptin are associated with better cognitive performance. So there's, one hypothesis, but then thinking about, why is obesity bad? Like, what are the mechanisms that are linking obesity to worse cognitive performance? So this could be related to insulin resistance. So reduced efficiency of glucose metabolism in the brain and insulin resistance and energy metabolism related effects, and also inflammation. So there is a study that I cited here that showed the association with C-reactive protein, inflammation, and how that could potentially explain the link between obesity and worse cognitive performance, because inflammation could have, neurodegenerative effects on the brain and negatively affect brain tissue. So those are some potential mechanisms, and there's a lot of other hypotheses out there. And we found that being underweight was associated with worse cognitive performance and higher rates of MCI, and the negative effects of being underweight were actually more pronounced than the negative effects of obesity, because and this we found interesting because there's so much emphasis out there on the importance of preventing obesity, but here our results showed that the effects of being underweight are really quite detrimental when it comes to cognitive function. And so thinking about mechanisms, so what are the reasons for being underweight? So first, malnutrition, and so I've cited a study here that showed that, and most of the studies I cited and describe are actually using CLSA data. So this study in particular showed that greater nutritional risk is associated with worse cognitive function, particularly amongst those age 55 to 64. So the impact of inadequate nutrition on cognitive function, I think, needs to be emphasized, as well. Being diagnosed with various medical conditions that lead to weight loss as well, and the effects of that. So making sure that any medical conditions are being managed effectively to prevent weight loss is important. And so why could being underweight be associated with worse cognitive function? And so it could be, loss of brain tissue. It leads to sort of loss of brain tissue, neurodegeneration, brain atrophy. Also, being underweight is associated also with greater inflammation. So just like obesity, inflammation could lead to effects on the brain, and also could be associated with other vascular risk factors and disrupt the blood flow to the brain as well. And so this is an area that needs further investigation. And we also found, so with regards to objective 2, we found that change in BMI was not associated with change in memory function. So as I mentioned, a small percentage had any changes in BMI and memory performance. So it might just be that the 3-year time window is just not long enough to really look at those associations between declines in BMI or increases in BMI and changes in cognitive function. So I think that a longer follow-up is probably needed. And we also excluded those who may have met criteria for dementia follow-up. So that was one of the exclusion criteria. So maybe these individuals are just no longer in the study at the follow-up period. So and then we also found that there were no significant interactions between BMI and cognitive function and various demographic factors that we entered into our model. So the relationship between BMI and cognitive function didn't really differ according to sex, age, or race. And I mentioned earlier that the number of non-white participants was quite low to allow, to look at relationships within specific cultural minority groups. So I do think this area needs further investigation, like why was memory performance lower in the non-white group, also why were the sort of rates of MCI according to our definition, why were those rates higher in cultural minority groups, and how could that be related to social determinants of health. And so I think this is an area that warrants further study. And then I'm just going to describe now the study limitations. So first, especially with regard to objective 1, this was a cross-sectional study, so we can't really infer any causal relationships. So what comes first is it's low BMI and then the impaired cognitive function. We don't really know what comes first, right? So there is a study that showed evidence for a bidirectional relationship between measures of adiposity and executive function. So there is, evidence for a bidirectional relationship. So we can't really infer causal relationships based on the study that we did and the fact that it was cross-sectional. Also, BMI as an indicator of obesity, there are sort of limitations to using BMI as a measure. So other measures like waist circumference, which is a direct measure of visceral adiposity, may be better. And BMI as well doesn't distinguish between muscle mass versus fat mass. And so that is a limitation to take into consideration. But I mean, BMI is sort of the most commonly used measure, and it's been around for a long time, but I'm just sort of acknowledging the limitations of that. And even when, I guess, classifying obesity, as indicated by clinical guidelines, there is a need to take a more holistic approach to not just look at BMI, but other comorbidities as well. So BMI in and of itself, it's one measure, but there are other factors that need to be taken into account. And in terms of our definition of MCI, it hasn't actually been validated. It was sort of a measure that one of our investigators had used in previous studies, so it's not perfect, but and so that is a limitation to keep in mind. And then the number of participants in the underweight category. So there were only 291 participants who were in this category, so less than 1%. So they were a very small percentage of the entire CLSA sample. So that is sort of a limitation when in thinking about the applicability and generalizability of the results that we found in our study. And so what does this study add to the literature? So we were able to replicate in a large Canadian sample the presence of this inverted U relationship between BMI and cognitive function. And we highlighted the detrimental effects of being underweight. So compared to sort of normal BMI in particular, being underweight was associated with the worst cognitive performance. And this was kind of surprising because so much emphasis is obviously placed on obesity and the detrimental effects of obesity, but our results suggest that underweight is very detrimental as well. And then this also suggests, the importance of developing strategies to prevent low BMI among older adults. So whether that's ensuring, that, or I guess supporting nutritional programs to ensure that, older adults in the community are getting adequate nutrition, vitamins, etc. That is important. Also exercise, so building that muscle mass is important. Medication management, so we know that certain medications may lead to weight loss, and so ensuring that this isn't a side effect of medications, and controlling weight effectively based on working with their pharmacist or physician, etc., to ensure that there isn't too great weight loss associated with medication use. And then regular health and dental checkup and visits. So as I mentioned, and as we know, certain medical conditions could lead to unhealthy weight loss. So staying on top of that as well. And in terms of, where we'd like to go next with this work, so we'd like to study factors mediating the relationship between low BMI and cognitive function. So looking at factors like nutritional risk, markers of inflammation, brain volume, vascular risk factors. So trying to understand, what could be driving this relationship. And then also looking to incorporate follow-up 2 data. So further longitudinal study to further investigate these relationships and see, particularly with objective 2, so looking at whether changes in BMI are across time are associated with changes in cognitive function, and maybe doing some more longitudinal modeling to determine, or be able to more accurately, determine is there a causal relationship there, because our study was cross-sectional. And so I'd really like to acknowledge the collaborators, co-investigators on this work. So Professor DeMoris from U of T Scarborough, who's our statistician, who led the statistical analysis, Dr. Chowdhury as well. And then the trainees who supported this work and really did all the analysis. So Caleb and Dewey from U of T Scarborough. And so I'm happy, here's my contact information. So I'm happy to take any questions.
Okay, well, thank you so much for a very interesting webinar presentation. We have a few questions now that I'll try to walk us through, several all from Michael Wolfson. And I think they relate largely to the measures, and the first one being, and I know you've touched on some of them, but maybe if you can go into detail a little bit more. So the first one is, there's increasing question of BMI as a measure of obesity. Can you comment on that hot topic?
Yeah, so I kind of put that in the limitations as well. So there's more emphasis now on sort of waist circumference, distinguishing between visceral versus subcutaneous adiposity. Also BMI doesn't distinguish between muscle mass versus fat mass. So there are other measures as well that could have been used in the study, but BMI has been around for a long time. It's a more commonly used measure, but I definitely acknowledge the limitations. And so yeah, it is a limitation, but hopefully in future studies we can also incorporate other indicators of obesity as well.
And the next question is, Flegel using NHANES quite a few years ago showed that overweight was actually healthier than being of normal BMI on longitudinal follow-up. Any comment on this?
Yeah, so I'm just going back to one of our graphs where overweight, so for mild cognitive impairment, there was no difference between normal and overweight. So there is maybe some evidence there that it's not as bad. So it wasn't significantly different than overweight, whereas when we went to obesity 1, then there was a significant difference. So I guess it sort of supports that in a way. So when it came to mild cognitive impairment, our results are sort of showing that overweight might not be as bad as obesity, and could potentially be protective. So but that was just for sort of the overweight category. Once you got into the obesity categories, the odds of MCI were higher and memory performance was lower. So
and next, there is other evidence showing important interactions between BMI and physical fitness. For example, overweight plus fitness leading to normal weight plus unfit. Could fitness have been taken into account?
That's a good question. I just don't know in the CLSA what kind of fitness measures might be most, I guess, levels of physical activity, or it's not something we looked at, but it's definitely something we can look at in the future for sure. I welcome any suggestions on what measures or, what data collected in the CLSA could be used as a marker of fitness to enter into our models.
Yeah, and the CLSA does have questions about physical fitness, also lots of mobility measures. So I'm sure maybe as a future research can take those into consideration.
Yeah, absolutely.
Okay, where are we now? So underweight can be a marker for possibly occult but serious chronic conditions. Was this controlled for at all?
Yeah, so we controlled for, we excluded individuals who had conditions that would affect primarily cognitive function. So as I mentioned, like stroke, Parkinson's, MS, epilepsy, dementia, also, but we didn't exclude other chronic conditions. So that is something we could potentially exclude, or we could include in our model, like the diagnosis of there's just so many different health conditions, and we thought about how can we control for this. So I welcome any suggestions, but we only excluded individuals with conditions that would affect cognitive function specifically. So
now question, the tracking cohort self-report height and weight, while the comprehensive cohort, these were measured. Typically, self-report overestimates height and underestimates weight. Did you compare the two cohorts and examine for different relationships?
No, that's a great suggestion. Yeah, no, we didn't, but I didn't know that. So I didn't know it was over. So that's a great suggestion for something that we can look at.
Lots of good ideas for future.
Yeah.
And body composition by BIA was measured at follow-up visits in the CLSA in the comprehensive cohort. Would fat measures from this be better than BMI?
Yeah, I think if it could distinguish between visceral versus subcutaneous, absolutely. Yeah. So, and this was just in the comprehensive though, correct?
Yeah.
Yeah, okay. Yeah, it's definitely something that we can look at for sure. Not something that we initially included in our application, but definitely, an area of future research that we could look at. Great suggestion. Yeah, thank you.
Yeah, and we do have a few more minutes, so if anybody does have any additional questions, feel free to pop them in right now. Is there anything else you wanted to maybe bring up, or any other burning questions or comments that you have, Nadine?
Not really. I mean, is there our measure of MCI? I don't know. Is there within the CLSA, is there any measure of MCI that's most commonly used? Or this was sort of, as I mentioned, our definition, which is based on impairment and preserved activities of daily living. But I'm curious if anyone in the audience has any other suggestions on how to, measure MCI or indication of MCI.
Well, if not today, maybe you'll get some follow-up emails. I see your follow-up email is in the chat right now. So
yeah.
So there's a comment, the CLSA is a rather biased sample, such as high percentage with post-secondary education. Isn't that a major limitation?
Yeah, I mean, we entered education into all of our models, and it didn't come up as significant, surprisingly, but yeah, like I showed in one of the tables, I think 75% had post-secondary. So yes, it is definitely a limitation that I think would need to be addressed in future research, or better controlled for. Yeah.
Looks like we don't have any more questions, so we can finish a couple minutes early. Oh, we have one more. For future studies, do you anticipate looking at biomarker data? That's something interesting. It would be interesting to see how inflammation factors in.
Yeah, absolutely. Yep. We were trying to look at, I think, C-reactive protein and I think it was TN1 alpha. So that is sort of in the works. We do want to see, could any of the relationships we identified be, explained by the presence or levels of these inflammatory markers. So that is something we do want to look at, but it definitely warrants further study as well. Yeah, so I think that's kind of a theme amongst all these comments, is incorporation of the biological, biomarkers in future studies, as we hopefully try to pursue this work further.
In other words, there are likely other mode effects comparing the tracking and other cohorts, not just how BMI was measured. Have these been explored?
I'm sorry, can you repeat that?
So there are likely other mode effects comparing the tracking and other cohorts, which would be the comprehensive cohort, not just how BMI was measured. Have these been explored?
No, we haven't explored that, but I think it's definitely something that we'll want to look at. Yeah.
So again, just clarifying that the mode effects are the phone versus the in-person. Phone being our tracking cohort, in-person being comprehensive.
Yeah, no, that's a great point. Something I didn't think of. So, and you mentioned phone. I think it was people report higher height, I believe. Yeah, so that's definitely something that we didn't take into account. We should look at as well with a comparison across those different modes. Yeah.
I think what I'll do now is close things up, and if people, we do have a few minutes, so if people do have questions, feel free to still post them and we can stay on after. So again, thank you today for today's presentation, and for everybody who's attended. I'd like to remind everyone that the next deadline for data access, if you're interested, is April 9th of 2025. You can visit the data access section of our website to review what data is available, as well as additional details about the application process. Also a friendly reminder for all CLSA data users of any change, please let us know of any changes that affect your data access agreement, such as have you moved institutions, has your research team changed, has a trainee graduated and moved on to a different position. You can always reach out to us at our email at access@clsa-elcv.ca with any questions or updates. And also, before leaving today, I'd like to remind everyone to complete your anonymous questionnaire to help us evaluate and get feedback. And finally, we're in the process of finalizing details for our next webinar. You can visit our CLSA website under webinars for more information on what that will entail. And remember, the CLSA promotes this webinar series using the hashtag CLSA Webinar, and we invite you to follow us on X at CLSA_ELCV. So thank you, everyone, and have an enjoyable rest of the day.